Good morning and welcome everyone to our CME today morning. So I'm Kelvin, House Officer at Emergency Department, UKM. So with today, I had my colleague Iqmal. So today our discussion will be on the topic of appropriate snake antivenom in Malaysia. So for today's schedule, we have the presentation first, then continue with a forum, a Q&A, and a quiz. So with us today morning, we'd like to welcome Prof Khaldun as our program advisor. And we have our three panelists today, which are Prof Dr. Satariya, Dr. Jörg, and also Dr. Zainal. So before we start, me and Iqmal would like to thank Prof Khaldun for the guidance and also throughout the preparation for this program.
Okay, to start off, few questions to be asked. One thing is, why do we need to talk about this topic? So, by numbers, the estimated deaths worldwide every year can go to the very least 20,000. It can reach up to 100,000. That's worldwide, yeah, every year. And in Malaysia, there's 15,798 number of reported cases from the year 2010 and 2014, with the average number of deaths per year from 3 to 4. And of course, there's a very severe lack of awareness and also knowledge among the public and healthcare workers in Malaysia. To be honest, me personally, before reading up on this topic, I really thought that one of the first aid for a snake bite is to suck the venom out of the wound. Turns out that's actually very wrong. Okay, never suck the venom out of the wound. Okay, so what type of venomous snakes we have in Malaysia? Three main species. The Elapidae, which consists of the cobras, king cobra, crabs, coral snakes, and sea snakes. They usually have long and thin plates, and their front fang is short and fixed, and they have this special ability to spray venom towards the eye. So we have to be careful with this one, especially. And then we have the Viperidae, which includes the Viperinae and also Crotalinae. But the main concern is the pit vipers, the Crotalinae, that's predominantly in Malaysia. So to compare with Elapidae, they have longer fangs, and the fangs are folded till the upper jaw, which can be erected during bites. And another one, we have Natricidae, which the most notable species is the red-necked keelback, which their bite can cause very significant coagulopathy. So what are antivenoms? Okay, antivenoms are basically molecules or fragments that are derived from the plasma that have been immunized with venoms. So we take one animal, we immunize with a venom, and then they produce this immunoglobulin, so we extract from them. So their mechanism of action kind of like immunotherapy, so they bind to the toxins, which then inactivate the toxins and also help with elimination and clear from the body. So there's two forms of antivenoms, powdered and liquid form. So the powdered form and liquid form both have their pros and cons. So the powdered form, they have a longer shelf life, so they can last the expiry usually about 5 years. And there's no cold chain that we need to care for. However, to prepare them, there's an extra step, which is reconstitution. And we have to store them below 25 degrees Celsius. And then the liquid form, they have shorter shelf life. And we have to maintain the cold chain. The storage temperature is about 2 to 8. So one needs to be in the fridge, one needs to be in the freezer. Okay. And then the antivenom further classified into two types, monovalent or monospecific, and then polyvalent or polyspecific. So as the name suggests, for monovalent, the antivenom, the production basically, they are immunized against one species only, and the antivenom is produced from that uh, from the immunomolecules. And then the polyvalent, the polyspecific. So one animal, they are given with different types of immunogen from different species, or it could also be that they take one or two or even more monospecific antivenoms and they combine to produce one polyvalent. And usually they are produced according to the syndromes of the symptoms that the snake envenoming produce. So one is neuropolyvalent because they cause neurotoxicity, and the other one is the hematopolyvalent because the snake bites from these snakes, they usually produce coagulopathy. And then there's one polyvalent antivenom that I would like to talk, which is the sea snake antivenom. It's actually made from one, one single species. However, it can be used with different types of sea snake envenoming. So, what are the indications for antivenom? Are all snake bites we have to give antivenoms? No. One thing is we need to identify whether the snake bites are from venomous or non-venomous types. And of course, we have to determine whether the snake bite is proven or is suspected with some symptoms, okay? Either systemic symptoms or local symptoms. So systemic symptoms and venoming such as the hemostatic abnormalities, in which there's a spontaneous systemic bleeding, there's coagulopathy, and also thrombocytopenia, neurotoxicity such as ptosis, and then ophthalmoplegia, there's drooling of saliva because there's paralysis, and also cardiovascular abnormalities such as hypotension and even shock, even worse, cardiac arrest, AKI, hemoglobinura and myoglobinura. And then for local envenoming, there's rapid extension of swelling. So this can be determined from the observation, we can see. And then there's also the draining lymph node, usually is enlarged and tender, or the local swelling is actually from the bitten part. The local swelling extend more than half of the bitten limb within 48 hours. So that's the indication for antivenom. So in Malaysia, we have actually, so here shown in the slide, 8 types of antivenoms, but actually there's 9. So I'll talk about these 8 first. So as you can see, from the top 4, monovalent, because you can see from the box, there's one species of snakes on displayed on the picture, and then the 2 at the lower right, you can see is hematopolyvalent, neuropolyvalent. You can see that on the box, you can see multiple species of snakes displayed. So I read it out for you. First, we have the QSMI. So QSMI stands for Queen Sahabah Memorial Institute, Bangkok. Okay. So Malaysia, we don't produce our own antivenom. We import from Thailand. So we have the Cobra antivenom, King Cobra antivenom, the Malayan crate, the banded crate, Malayan Pit Viper, Green Pit Viper, and then the hematopolyvalent and neuropolyvalent. And it's nice that they kind of color code it, right? So we don't, we can avoid making errors when choosing antivenom. So for the liquid antivenom, I said there's 9, right? So the liquid antivenom we can use for the sea snakes family. I said earlier that the liquid form for one, so from this polyvalent one, and I mentioned that for the sea snake antivenom, they are produced from one species. However, they can be used for the whole family of sea snakes. So for in case of sea snakes bite, envenoming, the first choice would be the liquid polyvalent sea snake antivenom. That's the only choice we have. So the initial dosing for the first choice would be 1 to 3 vials, and if necessary for further dosing, further treatment, then usually the subsequent dosing will be in 1 to 2 hours. So basically, now I'm talking about, I'm moving to the appropriate snake antivenoms for Malaysia. So I will show a picture, the name, the scientific name, and also the local name. The first choice of antivenom, the second choice if they have, and then the dosing, and also the geographical distribution, because it's important that we know the geographical distribution, because one thing, the nearby hospital can keep a supply. Let's say for the monocle cobra, it's not distributed to Sabah Sarawak, so they don't have to keep it in supply because it could be a waste of resource. So it's better that the hospitals at surrounding geographical distribution to have it in supply. And also it's also important to know the dose of the antivenom, because it also determines how much a hospital should keep in stock, the number of vials they have for a particular antivenom. Okay, so first one would be the monocle cobra, or Naja cayutia, famously known by the locals as ular sendok. Okay, you can see from the picture. Yeah, it looks a bit scary for me. The first choice would be the monovalent cobra antivenom. The second choice, we can use the neuropolyvalent snake antivenom. And for the first choice, the initial dose would be 5 to 10 vials for local, systemic 10 vials with subsequent dosing of 1 to 2 hours. Okay, so they are distributed to the northern and also to the western part of Peninsular Malaysia. Okay, you can see here. Next, we have the spitting cobra, ular sendok sembo, Naja sumatrana. Okay, so this snake, for the envenoming by this snake, we can use the same monovalent cobra antivenom as the monocle cobra, because there's a cross neutralizing effect. What do I mean with cross neutralizing effect is they share similar toxin antigen that the antivenom can bind. So that's what I mean with cross neutralizing. So for this also we can use as a second choice the neuropolyvalent snake antivenom. So similar dosing, 5 to 10 for local, systemic 10 vials with subsequent dosing of 1 to 2 hours. So you see this spitting cobra is spread worldwide. I mean, not worldwide, sorry, across our nation, Peninsula, and also Sabah Sarawak. Okay. Next is the king cobra, ular tedong sela. So the other name is, scientific name is Ophiophagus hanna. So this snake has its own monovalent antivenom, so the king cobra antivenom. And then the second choice would be the neuropolyvalent, same as the other cobras, but for this one, either local or systemic, we just straight ahead go with 10 vials with subsequent dosing of 1 to 2 hours. Okay, so same distribution, Sabah, Sarawak, and also Peninsula. So next, moving on with the Malayan crate. Okay, have a look at how the stripes of the snake is. So famously known by the locals as Ula Katam Tebu, scientific name Bungarus candidus. So for this one, there's monovalent for the envenoming, which is the Malayan crate antivenom. So the second choice is the same also, neuropolyvalent, because of the symptoms. The envenoming from this snake is mainly neurotoxicity. So for the first choice antivenom, initial dosing will be 5 vials with subsequent dose 1 to 2 hours. So for Malayan crate, the geographical distribution is mainly in Peninsular Malaysia. Next, we have banded crate. You can see black and yellow, Ula katambelang, known by the local as Ula katambelang, Bungarus fasciatus. So we use the monovalent banded crate antivenom. The second choice would be the neuropolyvalent as well. And then the initial dose of the first choice is 5 vials with subsequent dosing of 1 to 2 hours. And you can see that is widely spread across Malaysia, Sabah, Sarawak, and also Peninsula. So next, we have the red-headed crate, Ula katam kepala merah, Bungarus flaviceps. So for this one, the first choice, we go straight ahead with the neuropolyvalent. So there's no monovalent for this one. So just use the neuropolyvalent snake antivenom, starting with 5 vials with subsequent dosing of 1 to 2 hours. So yeah, geographical distribution the same, Sabah, Sarawak, and also Peninsular Malaysia. Next, we have the corals, the banded Malaysian coral, the Malayan blue coral, and the spotted coral. Ula pantai biru for the Malayan blue coral, Ula pantai bintik for the spotted coral. Okay, so for these corals, we don't have antivenom for them. However, if develop symptoms of neurotoxicity, we can use anticholinesterase such as neostigmine and atropine. Okay, so the banded Malaysian coral is in Sabah, Sarawak, and Pahang. Malayan blue coral nationwide, Sabah, Sarawak, and Peninsula. The spotted coral mainly in Peninsular Malaysia. We move on to the Malayan Pit Viper. So viper, in general, we call Ula kapak. So this one, locally known as Ula kapak bodoh, Calioselasma rhodostoma. Okay, so for this one, there's the monovalent antivenom for the snake envenoming. So we use that one as a first choice. And for the pit viper, usually in general, we use as a second choice the hematopolyvalent snake antivenom. So the initial dose for the first choice of antivenom will be 4 vials, and if needed for further dosing, the gap will be 6 hours. So the geographical distribution mainly on the northern part, northwest part. Okay. We have on the slide 3 vipers, pit vipers. Okay, one is the palm pit viper, the middle one is the Sumatran pit viper, and the last one mountain pit viper. Okay, so for all 3, for these 3, we can use the same basically, the monovalent green pit viper antivenom, and the second choice would be the hematopolyvalent snake antivenom. Initial dosing for the green pit viper, the first choice, 3 vials, and subsequent dosing 6 hourly. Okay. The palm pit viper, you can see from the distribution, Johor, Pahang, and then Kelantan. Okay. The pit vipers nationwide, Peninsula, Sabah, Sarawak, and the mountain pit viper in Pahang. Okay. So moving on to more pit vipers, we have the bright green Hagen's green pit viper. We have the mangrove pit viper and the Siamese Peninsula pit viper. So you can see that for the pit vipers, we use as a first choice the green pit viper antivenom, and the second choice the hematopolyvalent snake antivenom. So they all use the same dosing. First, the initial dose of 3 vials and 6 hourly subsequent dose if necessary. So the Hagen's green pit viper mainly in the peninsula. So the mangrove ular kapak bakau. So the western coastline, and then the Siamese Peninsula in Peninsular Malaysia. Next, we have more pit vipers. One is specific for Tioman Island. So this guy here, the Tioman Island pit viper, geographically in Tioman Island, as the name suggests. And then the Cameron pit viper, as the name suggests, in Pahang, so Cameron Highlands. And then the Wagler's pit viper or the Temple pit viper in Peninsula. So the same as the other pit vipers, the first choice would be the monovalent green pit viper. The second choice would be the hematopolyvalent snake antivenom with 3 vials as the initial dose and 6 hourly 6 hourly dose. Okay. So for the Temple pit viper, there's an error here. As I'm informed, actually there's no antivenom needed for Temple pit viper and also for the Bornean kill pit viper. Okay, so not needed. Actually, this one, the Temple pit viper, no antivenom needed, and also this one, the Bornean kill pit viper. Okay. But the Kinabalu and the Sabah green pit. Okay, so now actually we are moving to the snakes. They are mainly in the Sabah and Sarawak part. So the first one is the Kinabalu brown pit viper. Okay, ular kapak perang Kinabalu, mainly in Sabah. And then the Sabah green pit viper, Sabah and Sarawak. Okay, ular kapak Sabah, ular kapak perang Kinabalu. So the same, first choice, the monovalent green pit viper antivenom, and the second choice, the hematopolyvalent snake antivenom with initial dosing of 3 vials and subsequent dosing every 6 hours. Okay, so this one, regular speed, again, regular speed, no antivenom, okay. Bornean kill pit, no antivenom needed, okay. Next, we have the Kinabalu green pit viper or the Malcolm pit viper, ular kapak Malcolm, mainly in Sabah, and the Bornean palm pit viper, ular kapak Borneo for Sabah and Sarawak. Okay, again, same. So in general, the pit viper, we use the green pit viper as the first choice, and the second choice, the hematopolyvalent snake antivenom. So I think it's easier to remember. 3 vials, first choice, initial dosing, and also subsequent dosing of 6 hours. So we've talked about the choice of antivenom, the dosing of the antivenom, but how do we prepare it, right? So I'll show you a video. show a video of how to prepare the antivenom. Okay.
This is a box containing neuropolyvalent snake antivenin. On the box we can see the species of the snakes that this antivenom covers and also the expiry date. Inside the box contains the powder and also 10 cc's of sterile water for injection that we use to reconstitute the powder. The most important step in reconstitution is to gently swirl to avoid foaming of the antivenom. The next step is dilution. First, you take the reconstituted antivenom and dilute it with 5 to 10 cc of normal saline or D5 for children, or 250 to 500 cc of normal saline or D5 for adults.
Okay. So you've seen how to reconstitute and also to dilute the antivenom. So we can see that each antivenom or each snake is given how many vials, right? So each vial we have to reconstitute and we have to dilute into the normal saline. Okay. So for example, the pit vipers, we reconstitute 3 vials and we dilute into normal saline or D5. Okay.
Okay, good morning. I'm Kelvin. So I will continue the rest of the part. So first of all, what's the choices and selection of the antivenom? So they are chosen based on the species and genus, and also must be selected by a physician trained and familiar with the management of snake bite in Malaysia. So basically, all antivenom is administered intravenously. So how the antivenom is prepared was being shown in the video in the intravenous with step of reconstitution and also dilution. Next is the antivenom should be infused slowly, starting slow with about 1 to 2 ml per minute over 10 to 15 minutes. Then was slowly increased to a rate that if no reaction occur to complete the infusion within 1 hour or earlier. So basically, before we administer antivenom, adrenaline is prepared to treat for any possible anaphylaxis reaction. So patients should be monitored during and for at least 1 after the completion of the intravenous infusion. And we had a serial chart of vital signs and also this clinical progression. So as Iqmal had shared about the dosage of the antivenom, so different species and genus had different initial dose of first choice of antivenom. Next is what's the observation of the response to antivenom? So So if in the case of adequate dose of appropriate antivenom have been administered, so the following responses will be observed. First is the general of the patient. So the patient will feel better, nausea, headache, and generalized ache and pain may disappear quickly. Second is the spontaneous systemic bleeding. So this usually stops within 15 to 30 minutes. Next will be the blood coagulability. So this is usually restored in about 3 to 9 hours. And also if any bleeding from the new and partly healed wound would normally stop sooner than this. So in the case of a stroke patient, so the response will be the blood pressure may increase within the first 30 to 60 minutes, and arrhythmia such as sinus breathy may resolve. So in neurotoxic envenoming of the postsynaptic type, which for Cobra bite, it normally begin to improve as early as 30 minutes. But after antivenom, but usually takes several hours. So in envenoming with presynaptic toxin in the snakes such as crickets and also sea snakes will not respond in this way. So a provision of adequate doses of antivenom does not always sufficiently arrest or reverse neurotoxicity. So in these patients, sometimes may require intubation and also ventilation in order to prevent any respiratory arrest. So for next, active hemolysis and rhabdomyolysis may cease within a few hours, and the urine returns to its normal color. So we will need to monitor the renal function for 3 to 5 days. So next, what's the criteria for repeating the initial dose of antivenom? So first will be the persistence or recurrence of blood incoagulability 6 hours after the completion of the antivenom administration. Next is in the patient who continue to bleed briskly, the dose of antivenom should be repeated within 1 to 2 hours. So in the case of a deteriorating neurotoxicity or cardiovascular sign, so the initial dose of antivenom should be repeated 1 to 2 hours. And during the administration, a full supportive treatment must be considered. Third, we were talking about the antivenom reaction. So if in the event of any antivenom-induced anaphylaxis, antivenom should be temporarily withheld, then to resume at a slower rate once the anaphylactic reaction has been treated and also resolved. So for the antivenom reaction, there's 3 types. First is the early anaphylactic reaction. Next is the pyrogenic reaction. And third is a late reaction. So we are talking about the early anaphylactic reaction. So it's onset within 2 to 180 minutes after the administration of the antivenom. So how it manifests? So patient will be complaining of itching, urticaria, there's dry cough, fever, nausea, vomiting, abdominal colic, diarrhea, and also tachy. So in more severe cases, may develop a severe life-threatening anaphylaxis. So as we have known that we must prepare an adrenaline on before the administration of antivenom to treat any anaphylactic reaction. So in this case of early anaphylactic reaction, adrenaline can be given at a dose at first sign of anaphylactic reaction. In adult, we give a 0.5 mg intramuscularly. For child, will be 0.01 mg per kilo body weight and be administered intramuscularly. So the dose can be repeated every 5 to 10 minutes or start IV infusion at 1 microgram per kilo per minute if the condition deteriorates. So for an addition treatment to adrenaline, we may give antihistamine, which anti-H1 and anti-H2 receptor blocker. So for anti-H1 will be chlorpheniramine. So for adult is 10 mg IV. For child is 0.2 per kilo by 0.2 mg per kilo in IV over a few minutes. For ranitidine, so in adult to give 50 mg IV, and in child for 1 mg per kilo over a few minutes. Next, we also can give IV hydrochloride as the additional treatment. So in adult will be 2 to 4 mg per kilo, as well as in children. But however, in children is 2 to 4 mg per kilo with a maximum dose of 200 mg. So for pyrogenic reaction, it's the onset of 1 to 2 hours. So the patient will complain of shaking, chills and rigors. There's also fever, vasodilation, and a fall in blood pressure. So in the case of children, febrile convulsion may be precipitated. So for the treatment-wise, it's the same as the early anaphylactic reaction. However, if added in pyrogenic reaction, the patient must be cool physically with antipyrotics, and also IV fluids is given to correct any hypovolemia. So for the last reaction will be the late, which is a serum sickness type of reaction. So will be onset of 1 to 2 days, so at the mean of 7 days. So patient will complain of will have fever, nausea, vomiting, diarrhea, itching, and recurrent urticaria, arthralgia, myalgia, and the rest. So in the treatment of late reaction, so normally patient will be given a 5-day course of oral antihistamine. So will be given chlorpheniramine at a dose of, for adult will be given 2 mg 6 hourly. And in children, will be 0.25 mg per kilo per day in divided doses. So if patient who fail to respond to the treatment of in 24 to 48 hours, so a 5-day course of prednisolone will be administered. So for adult, will be 30 to 60 mg per day in divided doses for 5 to 7 days. For in child will be 0.7 to 1 mg per kilo per day in divided doses for 5 to 7 days. Okay, that's all from my part. Thank you.
Okay, earlier in the beginning, I mentioned the importance of knowing the geographical distribution and also the dosage of snake envenoming. So comes to the question, how many antivenom should a hospital keep at any time? Okay, so the formula is A times D times S times T. So A is the average estimates of snake bites requiring antivenom, okay, from a particular species per month. However, we need an annual retrospective or prospective survey in that hospital, okay. So this includes information like incidents, snake species, indications, and whether or not the antivenoms are administered, and the total amount used and outcome, okay. And then D is the recommended maximum dose of antivenom for treating a systemically envenomed patient. Okay, so we always multiply 2 for the first dose. Okay, and then the S is the safety factor to ensure greater than minimum stock is available. So the recommended is 1.2, and T is the time interval in months that is normally required to replace or replenish the antivenom use. So this depends on each hospital. Okay, so for this example, you can see in the bracket I've written example. So let's say in hospital Iqmal, one day I will open a hospital, who knows. Okay, so in my hospital, the average estimate of snake bites requiring antivenom for that month, after data from a year, so the average estimate is 2. Okay, and then let's say one snake, pick a snake, and we say that we use 10, the maximum dose. So 10 times 2 equals 20. Okay, and then we use the safety factor 1.2, and then the time interval. Okay, since my hospital is not so rural but also not in the middle. So let's say every 2 months, I can resupply the antivenom use. Okay, so 2 from the A, 20 from the D, 10 times 2 gets 20, times 1.2, the safety factor, and also 2 months. So this sums, the total will be 96 vials. Okay, so at one time, I need to have 96 vials for, for a particular antivenom. Okay. So these are the references for today's slides and presentation. The Malaysian guideline for management of snake bite, and also the book, photo book of land snakes of medical significance in Malaysia. And then most importantly, the Malaysian Society on Toxinology website. So I hope everyone can open that link, mstoxinology.blogspot.com, and have it bookmarked, because who knows, one day you might need to refer or to read up on snake bites. Okay, so who to call if you are uncertain with clinical management of toxinology related cases. So as you all know, the RECS, the Remote Envenomation Consultation Services, is one of our collaborators. So on the slide, you can see the names of the doctors and also their contacts. Okay, this you can find from the MS Toxinology blogspot. There's a tab called info. So from there, you can find them in the, I think, in the guideline for healthcare. You can see in the guidelines, you can see the contact list. Okay. Oh, okay. Okay, this is old. Okay, there will I'll share an updated one later. Okay. And then what else before I Malay Pit Viper? Okay. So some correction. The Malay Pit Viper, the initial dose is 3 vials. Okay, some correction. This one. Okay, and then I would like to highlight one more thing regarding the subsequent dosing. You see, this is like a suggestion. Okay, because if we go back to Kelvin's discussion, whether or not we need to repeat the next dose. So if necessary, so we should give it earlier. Okay, 1 to 2 hours. Okay, so we don't have to follow like black and white. Okay. Okay. That's all for our presentation. Thank you, everyone. Please don't leave. There's a Q&A session with our panelists. So with that, I would like to introduce our panelists for today. The first panelist I would like to introduce is Dr. Zainalabidin bin Mohamed. So he's currently the chairperson of RECS. He's currently a consultant emergency physician in HTAA, Pahang. Okay. Special interest in emergency medicine, clinical toxinology, pre-hospital care, and also disaster medicine. Okay. Next, we have Dr. Jörg Blessman. Okay, he's currently in Hamburg, I suppose. So very early in the morning, where he is right now. So a very big Dankeschön from us, okay, for being up so early to join the Q&A session. So we have Dr. Jörg Blessman. He's from Hamburg, Bernhard Nocht Institute for Tropical Medicine. He's the head of the working group Snake Bite Envenoming, Surveillance and Control. So with special interest in epidemiology of snake bite envenoming and respective snakes, and also clinical toxinology. Okay, next we have Prof Satariya Trakulsrichai from Thailand. She's the emergency physician and clinical toxicologist from the Department of Emergency Medicine, Ramati Body Poison Center, Mahidol University of Bangkok, Thailand. So everyone, please welcome them. I will read out any question, but first I would like to show I would like to share one news article. Okay. Before that, let's have a few words from our panelists. So maybe we start with Dr. Zainal.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good morning. Thank you, Iqmal, and thank you for the organizing committee for inviting us to be a panelist on this session. And thank you. A good presentation. I think Prof Khaldun already make some point to some corrections regarding the dosing of the Malay Pit Viper. Instead of 4, it should be 3.
Okay.
And then about the antivenom for the regular temple pit viper and the submodulators. And then I think yeah, you have mentioned about all the antivenom. Probably the supply of the antivenom, the duration of waiting time is not necessary about the how remote the hospital is. It's actually how the manufacturer can how local or your hospital can buy, and the duration how long they can able to get the supply. That is also depending on the availability of the stock in Malaysia, and as well as how the manufacturer can provide you how long they can give you the stock from their manufacturing factory. So just my short comment on that. Otherwise, your presentation is good. Thank you very much. I'll leave it to other panel to just comment.
All right, thank you.
Thank
Thank you, Dr. Zainal. So next, I would like to invite Dr. Jörg Blessman. I hope I pronounced it right.
Yes, you did. Good morning, everybody.
Morning.
So sorry, I think I missed a little bit of the presentation. I was thinking everything starts at 4, but it was already 3 a.m. here in Germany. Anyway, thank you for the invitation. I'm here, I'm awake, and well, maybe because I could not follow all the presentation. Only the one slide I saw on treatment of early anaphylactic reaction. Maybe there can be some discussion. I don't know. I always I had I read the recommendation of treatment of anaphylactic shock from the International Association of Allergic Reaction. And I think the hydrocortisone and the H1 blocker is probably not working very well, and adrenaline is still the treatment of choice. And with adrenaline, you will reverse the reaction, and you probably don't need I know that everybody is doing, and we do it also here in Germany, even for prophylactic treatment. If somebody said, I had an anaphylactic reaction against contrast media, there's always H1 blocker, H2 blocker, hydrocortisone, and for prophylaxis also. But I think the evidence that this is really working has to be revised, and we have to think about this. Okay, and the rest maybe we can also discuss during the session. Yeah, thank you by now.
All right, thank you, Dr. Jörg. Next, a few words from Prof. Satariya.
Really? Good morning, everyone, and thank you for inviting me to be a panelist in this conference. And I have some comments. And your presentation is very excellent and knowledgeable and interesting. I would like to comment on, like, if you know where the snake bite or snake habitat is in each regions of Malaysia, I think that maybe you can distribute the antivenom based on the locations of the habitat of the snakes or snake bites. Like sometimes you will have some snakes bite in only some regions of Malaysia, so you might not need for every antivenom stock in that hospital in that regions. I think by that, and so from the habitat of snakes, you might know where you should stock the antivenoms. I think that you guys have already done it. And the second one is you mentioned about the dose for 1 or 2 patients in each small hospital. But if the patient needs the second dose, like you mentioned that for neurotoxic snake bite, you need the second dose within like only 1 or 2 hours. You might think about if you have the more stockpiles of antivenoms in the larger hospital, like provincial hospital that is nearby the small hospital, to supply more antivenom. That the one of I think that is it's important issue because some patients might not need only 1 dose, but need more doses to correct all coagulopathy or neurotoxic systemic envenomations. And another one that I think in my experience, some snake bites or the envenomations or the bite from like Bangladesh Faviceps or coral snake in Thailand, we don't see any systemic toxicity or envenomation from those snakes, right? Bangladesh Faviceps or corals, or even sea snakes. The systemic envenomations or toxicity does not occur commonly, or in my experience, I don't see any patients with systemic symptoms from those snakes. So I think that from your study or retrospective review, you might know that maybe some snakes might not need any antivenom. And another one that like for green pit viper that are not Trimerazurus species. Like now we have mountain pit viper that is Ovophis convictus. Now we cannot use green pit viper antivenoms to battle with the envenomations now. We use a lot of vials of green pit viper antivenoms, but it did not work well with those with the previous Trimerazurus species, but now it changed to another species or genus. So that that I would like to comment. Yeah. Thank you.
Thank you, Prof. Satariya. Okay, maybe a word from our supervisor, Prof Haldon himself.
Yes, thank you so much. Excellent work by the moderators. I would like to just say thank you to the panelists for joining us. This is a very interesting and I think timely topic to discuss as we have some issue also with antivenom supplies in the region and also lacking of really understanding about how antivenom works for our envenom patient. So I think we've put forward some points that worthy for discussion. So maybe there are some questions the moderators would like to ask our panelists.
Sure, Prof. Okay. First thing is I'm sharing a news article recently, so I'll translate. Okay. The family basically thought that this 2-year-old boy, Fayyad, basically they thought that he fell down. Turns out he had a snake bite. Okay. So 2 years, 2 years old boy basically died from snake bite. So ular tedong sela is king cobra, right? King cobra, yeah. While on vacation to her grandmother's hometown. So on Sunday. So basically, the father commented on the incident that he saw two holes or like wound on the right leg of Fayyad that bled. So first he brought into the house and cleaned the wound. Okay, our whole family did not know what caused the bleeding. We thought that he fell down, but there's no abrasion or scratch. So I brought my son Fayyad to the nearest hospital, which is Kuala Nerang, for further investigation. Okay. Sooner, they found out that at night, Fayyad was crying in pain. Okay, and then they found that Fayyad was rubbing the legs in pain, and the legs are swollen, and they found that Fayyad to be weak and no longer responding. So then Fayyad was further referred to a bigger center, okay, for critical care. So the father also said that he never thought that his son behavior, basically there's loss of appetite, he didn't want to eat rice the whole day, would be the sign that his son would go away forever. Okay, so any comment from the panelists?
Yeah, maybe I try to say something for this case. Yes, I think there's a small percentage of patients coming to hospital where you maybe don't know directly what is the reason for the wound or what is the reason for even a bite. So that can be always an animal bite, that can be an insect bite like a centipede or scorpion, which is also inducing pain and swelling like a snake bite. So if it is and of course if it's a small child like a 2-year-old child, who cannot respond properly, maybe what had happened. So we always have to ask, of course, but a very young child may not be able to answer properly. And but beside this case of a child, of a very young child, there's always a small percentage where you don't know what kind of bite that may be or may have caused the symptoms. But I think we can always go ahead with a syndromic approach, look for coagulation disorder, do the laboratory test, do a proper neurological examination. Is there any signs of neurotoxicity? And then step by step approach these kind of patients where we are not sure whether it's an insect bite like a centipede or scorpion. I think in Asia, scorpions are also can do also maybe a little bit of swelling and pain, especially. And but if there is only swelling and pain, then you can just observe the patient, and at the end of a period of maybe 24 or 48 hours, say, okay, probably it was an insect bite, or if it was a snake bite, there is no indication to give antivenom.
Thank you, Dr. Jörg. Okay, we have one question from the viewers.
Maybe Prof Satariya want to add on, then Dr.
Okay.
also.
Right. Okay, sure.
Okay, thank you for interesting case, and I agree that it's quite very difficult if you don't know exactly that what kind of animal that bit or caused the wound. But I totally agree with Dr. Blessman that we have to observe or use the sign symptom of the patients to guide the management. Like if the patient could not breathe appropriately, so you can intubate the patients and save the life, even you don't know exactly the snake bite or not, or which kind of snake, or from the basics that you might use it to guide the management. And I remember that I forgot one point that I would like to comment, that for the neurotoxics, because this case is king cobra bite. So neurotoxic snakes, we
actually we don't know the species. This is the report by the reporter.
Okay.
But nobody saw any snake.
Okay.
Actually, so this is just a report, wrong, misleading reporting that I want to point out as well. So, but nobody see any snake that bit the patient.
Yeah, and I would like to.
Based on the symptom provided, what do you think?
So if the patients die without any obvious sign, symptom, or abnormal laboratory, maybe it can be like neurotoxic snake. And if the patient was not observed appropriately or properly in the hospital, like for respirations, or if they can die, I think. Yeah, because stop of breathing or something. If we did not observe the patients very well, that, yeah, I agree with Dr. Blessman that maybe we have to use the symptomatology of the patients to guide our management. Yes. And I have some comments and would like to ask for the panelists or Dr. Khaldun opinions that if the patient needs the first dose of neurotoxic snake bite, and for the second dose, like the WHO might say 1 or 2 hours, if the neurologic symptoms progress like that, if the patients that not have any progressions of the neurotoxics, like the moderate grade 1 to the grade 1, in my practice, I do not add more for the second dose or more antivenoms if the patients that not have any progressions of neurotoxic symptoms. But what is your opinion about that? Thank you.
We'll save that first. We'll let Dr. Zainal comment, and maybe Dr. Zainal can also comment on that question.
I'll comment about the case presented first. I try to comment. I'm not sure because I heard the other side of story behind this statement from the newspapers. But I think I agree with Dr. Jörg and Prof Satariya. So probably the best how to approach this patient, we need to approach based on symptomatic or based on the syndromic approach, either which syndrome this particular patient has that is most likely is neurotoxic, and then the choice of antivenom, we should investigate whether what are the choice of antivenom, whether the antivenom was given at that hospital and was the antivenom given appropriately in terms of the choice of antivenom and the amount of the dose of antivenom was adequate or not during that time. So probably we have to investigate further on this patient. Yeah, that's my comment on this.
What about the one that Prof Satariya asked? Do we need to top up? When do we top up? Should we top up if there is no worsening of the case?
What we do usually, if you give the antivenom, if there is improvement of the symptoms after 1 or 2 hours, then we don't top up. We just observe and we wait until the patient improved. If wasn't or there's no improvement, then probably we top up the dose.
Jörg?
Yes, neurotoxic envenoming is always much more difficult because the neurotoxins are usually small molecules. They are only 7,000-8,000 Dalton, and if they have left the blood circulation and moved to the neuromuscular synapses, then I think usually we lost already with the antivenom. So we have to be very early and neutralize the venom components within the circulation. But if the venom is gone out of the circulation, it's very difficult to reach the venom components. And then I always say you have to be early and give a high dose at the very beginning. And I even do this also for crate bites, for Malayan crate. I usually give 10 vials at the beginning just to be sure that I can do the most or can neutralize most of the venom. And for Cobra bites, also, it's 10 vials at the very beginning to be really sure to try to neutralize all the venom which is circulating. And for Cobra bites, it's maybe also more important because you have the swelling and maybe some venom is trapped at the bite site and is resorbed after. So that's also very important. Maybe even more important if there is no improvement to give a second dose. For crate bites, I think a second dose probably won't work. You would maybe do it just to do something, but I think normally you lost. You have to be very early to neutralize the venom within the circulation.
Maybe Dr. Zainal want to share some of our RECS experience with managing such patients.
Antivenom.
Yeah, so there is actually a lot of things going on at the same time because it's not just about symptoms. We are looking at first the species of the snake as well. And even if it's the same species we know in the region, they probably act differently to antivenom that is available. For example, our antivenom is from QSMI. For Cobra, maybe for the spitting Cobra, for example, is different from the spitting. The effectiveness is different from each country of origin. For example, it works well in Thailand, but it's probably less well in Malaysia or even Laos. So that could play a role as well in terms of the amount of antivenom to be given as the first dose or the top-up dose. Secondly is also, as the Jörg mentioned, if is, for example, the postsynaptic binding to the neurosynapse, to neuromuscular junction, then we have to target early antivenom, yes, of course, and most likely the top-up dose of antivenom may not be of any benefit because the binding is almost permanent and causing damage already to the neuromuscular junction. Slightly different to the presynaptic binding. For the Cobra bites, it's a postsynaptic, right? Jörg?
Yeah.
Yeah. So
yeah.
For the crate, it's a presynaptic binding. So the presynaptic is a bit more permanent. Sorry, I got mixed up there. But the postsynaptic could be in a flux. It may not be totally 100% binding fully. It can still be like a competitive binding, and that's where the concept of giving acetylcholinesterases and what do you call these competitive analogs can help to unbind the postsynaptic bind of the neuromuscular junction for Cobra, for example. So in that sense, that what Satariya was saying, most likely then the top-up dose may not be really necessary for the patient. But if, let's say, as we have already seen, as Dr. Zainal said, we give the first dose and the patient recovered. And after, for example, 12 hours or 24 hours later, the patient had a recurrence of the symptom, means that it has already improved and then it becomes worse again. Then that's where another dose of antivenom may actually be helpful. And we see this even in Bangkok, Thailand. You know, our snake vet in QSMI, Dr. Tatsa, he got bitten by a cobra, monocle cobra. He received the first dose of antivenom. He recovered and went out of the ICU to the ward. Then he redeveloped the symptom of neurotoxicity, and they had to give him again the next dose of antivenom. So we see also, as Jörg said, the swelling can form a depot of venom in the local area, and it will resolve as the swelling resolve. The venom will shoot out into the circulation better, and we see this in cases, for example, in Malaysia. Dr. Zainal can confirm this, of our pit viper bites, patient green pit viper. We see in the blood test, we do regular blood tests for coagulopathy and platelet count. We see they correct this abnormality very fast with the first dose of antivenom, but 24 hours later they start become better, and we see the patient develop recoagulopathy again, and especially so when the patient feel better, they start to move around, they start to walk, you know, and that actually cause the depot of the venom in the bitten area to go into circulation faster through the lymphatics. So we always ask the patient to be strictly rest in bed after a bite until a few days, rather than walking to the toilet and so on. Those are actually the one that our so-called traditional medical practice is that if patient can walk, means patient is okay. But this is not true for snake bite patient. The faster the patient walk, the more worse that the patient can get. So our young doctors think that, oh, patient is walking, ambulating well, they are actually better. It's not true for snake bite. It's actually can cause more harm to them when they increase the physical activities. So that's it. That's from me. Very good. You have any more questions, moderators?
Yes, the first question from Afni. So asking why there is no antivenom needed for Borneo Keel and Waggler's Pit Viper, and what are the common symptoms? Yeah. Why is there no antivenom needed for Borneo Keel and Waggler's Pit Viper?
Yeah, Dr. Zainal?
Based on our experience and based on the what we get it is from this species of snake bites. They seldomly they don't presented with the severe much of symptoms, and even the coagulation is not affected at all, much or at all for this type of species. And then the symptoms is quite mild, and then it doesn't require, number one, it doesn't require antivenom. And number two is there's no, the antivenom that's available is not say neutralizing the venom itself. It doesn't cause too much harm to us. And then I think the antivenom is not. Then I leave it to Prof Satariya. Probably can comment on the neutralization of the antivenom towards those species. But based on our experience clinically, does patient mild symptoms, and then we don't even need antivenom for these two species. Thank you.
Prof Satariya, you want to comment something? Why QSMI don't produce antivenom for Tropidolemus species?
I'm not sure that the Borneo Q and Waggler Pit Viper are.
Borneo is also Tropidolemus subannulatus. Both are Tropidolemus genus.
Okay, so it's a rear fang snake.
No, it's a pit viper.
It's,
Tropidolemus, yeah, temple pit viper.
okay. So I agree, because like I mentioned that in my experience that the snakes that are not Thymelasurus, the antivenom for in pit viper that produced by our Thai Red Cross might not neutralize very well in my experience. For like mountain pit viper that in the past we used green pit viper, and it works well in the past, I think. But recently, like one of these 2 years, we have the cases and it did not work well with the patients. Sometimes we use a lot of vials of antivenoms to combat with the envenomations of that patient. So I think we have to review the cases with the hematotoxic snake bite patients with that are not Thymelasurus, and look for the data that it works or not. And sometimes we have the real fangs snake in Thailand also, and it does not work well with green pit viper or even polyvalent hematotoxic antivenom for those snakes. Like now we have the case that we don't know exactly which snake that bit the patient, but the patient had severe coagulopathy, cannot count for INR or PTT, and even we use polyvalent hematotoxic for more than 20 vials, it does not change anything, and the patients had GI bleeding, even pee or everything, it did not work. So now I think that we might face with the problem with real fang snake that we call red keelback snake. Like I'm not sure that it's the same in like in Malaysia.
Yeah, so now the Rhabdophis subminiatus has now changed the names to several species now. So we share the same Rhabdophis siamensis with Thailand at the moment. Yeah, there is a new upcoming issue with this Natricinae snake groups. Okay, so we have no antivenom specific for them except for the one for the Yamakagashi Rhabdophis tigrinus in Japan. But then the antivenom stopped production more than 20 years ago. So yeah, maybe Jörg want to comment a bit about this issue?
Yes, for Laos, I can say we have also Rhabdophis subminiatus bites, or it's, I don't know whether it's Rhabdophis siamensis or what kind of subspecies that was. At least it's a red-necked keelback. I don't know really the exact species, but we had actually in the last 3 years, 2 cases, and the same experience. In one case, we gave polyvalent Thai hematotoxic antivenom, and nothing happened. And the young boy had a coagulation disorder with a PT more than 120 seconds, so unmeasurable coagulation for 7 days. And that was a very difficult situation for us. At this time, actually, I asked for antivenom against Rhabdophis tigrinus in Japan, and they were they sent 2 vials, but when the vials arrived, then the coagulation disorder resolved, so we could manage the patient without antivenom. But I think it's in these cases it's very important to have a potent antivenom. It's very rare. I saw only 2 cases, and I think Vietnam has also a lot of experience in the south. They have a case series, I think about 32 or 34 cases, and 4 patients died in Vietnam. So it's an important snake bite with high mortality, 10%. Also, the Japanese have the same experience. Before they used the antivenom before 2000, they had also mortality, 20 cases, 2 died, when I remember right, also 10%. So it's an important bite, rare, but I think we need a small stock of antivenom. That is the same thing the Japanese did. They had a small stock, not registered antivenom, which they used for their 1 case per year. But in this 1 case per year, it is quite important, and the Rhabdophis tigrinus can really cause severe envenoming. That is definitely the case. And antivenom, which is available in Thailand, the Trimeresurus or Malay Pit Viper or polyhemato is not working against this.
Yeah. Okay. So so that's the point that we want to make, that you know, even if we have a small stock for the region, for example, and it can be actually temporary. Produced not for long term, but maybe for short, just to get the stock, and that can be actually keep for a long time. And that's what's happened with the Rhabdophis tigrinus antivenom, more than 20 years, and still can be used, and it is found still keep well, and potency still remain almost the same. There's no degradation of potency of the antivenom. So I mean, the one that our presenter present about the shelf life of the antivenom, that's just a number that they put. But actually, if you keep long, I mean, we found some of this antivenom can still work well, as we have already experienced with expired antivenom for Laos, for the Malayan Pit Viper. So I mean, even expired for more than 2 years, it can still actually reverse the coagulopathy without so much increase in the side effects of the antivenom. So that is something that really, we really have to look seriously, I think, for the region when we are trying to produce this so-called rare antivenom for our so-called rare cases of envenoming. About that case, Dr. Zainal was commenting just now. Yeah, it is true that we don't know what is the details that needs to be, looked back in detail, and but the media has already put judgment that the case was caused by a king cobra, which I think is very strange because no explanation was provided how that diagnosis of king cobra came about. So that is also a wrong thing to do, and it can cause more harm, especially in the public domain. Needs to conduct a proper mortality and morbidity meeting for that case in order to justify the death of such a young life. We have very rare, I think almost never before in Malaysia that we know of a death caused by a pit viper. So that's one more issue as well. And whether most from the report, the news report, it sounds to me more like a neurotoxic. It's true, it sounds more like a neurotoxic bite. And we know in that region, in that area, there are cobras as well. Very unusual for a pit viper bite, and you can't find a pit viper near the patient, especially the Malayan pit viper. The cobras will run away fast, so that's why you can't find any snake near the patient. So it's something to think about, and we have to find justice for the death of this child, whether it is unnecessary. In Malaysia, we are already targeting 0 death for snake bite. That's our campaign now. 0 death for snake bite in Malaysia, because we have very small number of bite, and we have rather receptive or rather good medical service, like in Thailand as well. Very quick. People go to the hospital quite fast for the treatment. Okay, any other question, moderators?
Okay, I think we have time for one last question. So one question from one houseman currently in our emergency department. So the question is there any contraindications or reactions between the antivenoms? For example, in a case when it's unsure of what type of snake bite, snake envenoming, so this patient initially was given neuro antivenom, but further history and clinical examination showed it is more of the I think hematological symptoms. So we decide to change or add antivenom. Is there any contraindication to change from neuro to hematopolyvalent, or any reaction between these two?
So far, none of no contraindication. If patient indicated to give antivenom, then there's no contraindication to give at the moment. But the decision to give antivenom, you must get a appropriate history and examination to determine which species and which syndromes that belongs to. So that's why your history, how you get the history, and you get how you examine the patient, how you get the signs and symptoms to go to the appropriate syndromes, and decision to take appropriate antivenom is very important. So if you're able to get those correctly, then probably there's no issue on giving a wrong antivenom or antivenom on the first place. However, I agree, sometimes the history a bit vague, and then sometimes the examination is a bit different, that that can cause you to give a wrong a different type antivenom. You just try to give, and then afterwards you noted that the history changed, and the symptoms, the other symptoms that just appeared, then probably during that time, then probably if there is any indication, then you have to give appropriate antivenom. But if you're able to get thorough history, good examination, and then I don't think you have a problem, and you shouldn't give a wrong antivenom. Thank you.
Okay, I think that's the time.
Maybe Dr. York want to comment, Dr. Satariya, about that?
Yeah, maybe for neurotoxic envenom, it's always also important to ask when the patient maybe come from a district hospital whether they give any sedativa. Then you may misinterpret very quickly, oh, that is maybe a neurotoxic envenoming, but it's actually the drug action which produce the symptoms. And I agree with Zainal, if you do a good patient history, you know what kind of drugs he got, and then the symptoms, and then a proper lab test for coagulation disorder, we should be able to really diagnose very fast the right syndrome and then give the right antivenom.
Okay, so can I just maybe there's one question in there. I just want to address that. Dr. Zainal already addressed the question about what are the signs and symptoms, warning signs do we watch for. It's very important. And I just want to add, if you see you give one antivenom, it should actually give you some response to the antivenom from your close observation after giving antivenom compared to before giving antivenom. So that's why close serial monitoring is very important, and that includes serial blood tests as well. So we'll tell you whether your antivenom is actually working or not. If it is a correct antivenom, it will have some improvement in a way to the signs and symptoms and also to the investigations. But if you gave the wrong one, or what we call the failure of therapy, and that's the one that you might have to think critically again, re-ask the question again, do the thorough investigations again, and then decide whether you were actually mistaken in terms of the diagnosis. What happens in Malaysia, from my experience, is the diagnosis from the emergency department carry on throughout the patient management until the patient is in the medical ward. You know, it's the same diagnosis. They never question the history back, and you know that is actually very dangerous, and that's the red herring for managing patients. So you have to be be critical in your assessment of patient, especially in the history as well. Sometimes we find that Dr. Zainal always we see this in Malaysia, patients tend to lie about their history also. So for whatever reason, they don't want to be put into the situation of being the one that caused the bite, rather than they put say always accidental, where they're playing with the snake, they say that they accidentally got bitten, whereas they're actually playing with the snake. So we see this also in you have to be you have to be mindful of when you're taking history. You have to have a bit of a pinch of salt to the truth of what you obtain from patient, and that can put you off guard when you are trying to make a decision, a clinical decision for the patient, especially in antivenom. Yeah, so be mindful of a failure of therapy that may require you to change your antivenom to a better one. Okay, all right. So I think that's all. I think the other information in the question and answer, you can always get it from the website link that the moderator has given. Is in the guidelines that we have here. What are the things to look out for when the patient is discharged and so on? What are the advice given? It's all in our Malaysian guideline on snake bite. Okay, so that's it. Thank you from me. Back to moderators. Anything else want to add?
No.
There are two questions. There are two last questions. You want to
address that? Yeah, please address that.
The two questions. You want to proceed with the two questions? The last two, I think. Yeah.
One thing, we are short on time, so this is
okay.
Yeah, but just maybe Dr. Zainal want to quickly finish that.
Okay, sure.
Okay. One about the how long we need to keep the snake bite patient. Is no one is depends on the progression and the response to the antivenom and treatment, and then we have different species of snakes. We have to keep patient on certain time. So I will not comment in detail on that. Number two, does the two fang, it must be two fangs marks? It's not necessary. Sometimes the fang broken or sometimes only one fang is bitten, or sometimes the snakes bite more than once. So there's the possibility the marks will be more than two or less than two. Thank you.
Okay,
And sometimes there could be more than one fang on one side of the,
so thank you for all panelists for being here and everyone on the floor, I mean on the Zoom, joining in for our discussion today. We have one quiz session. For the quiz session would be a hard copy of the land snakes. So this book, the ebook I use a lot in current presentation, and autographed by our beloved supervisor, okay, Prof Haldon himself. So it's rare, okay. So now time to kick those caffeine in, okay, and be sharp. So we have a quiz session. We'll be using Kahoot, okay. So anyone with a phone can join. So just go to kahoot.it.
the print copy of the ebook is very rare. It's limited print copy, so it's a collector's item. All right. You can auction it in 10 years time.
So we'll begin now. Good luck, everyone. Congratulations. Yeah. Can the winner personally, I don't know, text in the Zoom, right? Thank you everyone for joining in. So before we end, we have e-certificate for today. Thank you for the panelists, Prof Satariya, Dr. Zainal, Dr. Blessman. Thank you so much. Thank you for joining in. Hope everyone benefit from this discussion. Hopefully you can share with your colleagues as well. I think Prof also gave a link to MS Toxinology. So yeah, any inquiry, any question can first view the website and have a look. Okay. Thank you everyone for your time and for your attention. Okay.
Thank you very much. Bye-bye.
Thank you, Dr. Blessman. Thank you, Prof Satariya. Thank you, Dr. Zainal. Cheers, cheers.